hepatitis B or HIV-associated nephropathy, or they have an opportunistic infection and now they have AIDS. The initial treatment goal is defined as obtaining an undetectable viral load. And that means when the viral load is less than 48 copies per ml, and you want to try to obtain this within 3 to 4 months of starting treatment. And a secondary goal is sustaining increased CD4 cell count. Treatment failure is defined as not being able to achieve the undetectable viral load goal within 3 to 4 months, of starting treatment. Or when they've already had achieved an undetectable viral load, and as you saw on that graph, they are now failing treatment and are developing unsustained viremia, uncontrolled. So prophylaxis, just a quick talk about that. When should you start prophylaxis? When the CD4 count is below 200, typically that's when you want to start prophylaxis. And you want to cover for these opportunistic infections. This table adapted from the AAFP shows that at 200 you want to cover for pneumocystis jirovecii pneumonia. You can use Bactrim or Dapsone. At CD4 less than 100, you want to cover for Toxo. You can give them Bactrim as well. And at a CD4 less than 50, you want to cover for things like Mycobacterium avium complex, Cryptosporidiosis, PML, and typically for MAC complex, you would give them Zithromax, 1,200 milligrams per week. So, Christian, which of the following drugs have been associated with hypertriglyceridemia? Is it rotenavir, hydroxyurea, delavirdine, abacavir, or stavudine? And excellent. The majority of you got it right. Rotenavir, which I believe is the only PI there, and is the one typically to cause these hypertriglyceridemia. So talking about drug adverse effects. So these patients, like the one that presented, the one case I had in my 3 years of residency that came for me to provide continued intermittent and chronic care for other issues, but happened to be on antiretroviral therapy for many years. Well, what do I need to know about those medicines that they're on, and in conjunction with managing them with an ID specialist? I should be aware of the ART, the antiretroviral therapy, drug adverse effects. They can cause a significant metabolic effects and morphological changes in the body. They may tell you that they're diabetic and I have peripheral neuropathy. You can't just assume it's from the diabetes. Maybe it's their NRT. They are an increased susceptibility for osteomalacia because if they're on NRTs and NRTs. And HIV itself, as I mentioned, predisposes to osteoporosis and osteolytic bone lesions and fractures. The PIs, the protease inhibitors, can cause a significant metabolic derangement in their lipid profile and glucose, and predisposes to hyperlipidemia, hyperglycemia, lipodystrophy, diarrhea, fatty liver. You have to be extra cautious when combining them with statins, as it can cause myopathy and rhabdomyolysis. Abacavir has been found on certain studies to be cause direct cardiotoxicity. So finally, we talk about immunizations to wrap up the role of the primary care physician. We talk about what vaccinations should they get, what is recommended, what should you be doing for them. So at each office visit, they should have their vaccinations updated. Okay. They can receive killed or inactive vaccines, but they should not be receiving live vaccines like varicella because of their immunocompromised state. If their CD4 count is less than 100, then you have to understand it may not mount an appropriate immune response, or if they're having uncontrolled viremia. So what vaccines should they get? Well, like the general population, they should get their yearly influenza vaccine. They should be recommended and advised and counseled to get that, as well as a pneumococcal vaccine once before the age of 65. They should be also considered to get a booster 5 years later. They should continue to get, like everyone else, a DTaP booster every 10 years. And if they have not been exposed to hepatitis A or B, they should get the full series. To wrap up the key recommendations from the AAFP, routinely those 13 to 64 years of age should be screened for HIV with testing, standard testing with the ELISA, and those who are pregnant and at increased risk. If you are going to start treatment in conjunction with an HIV or ID specialist, they should typically get 2 NRTs and an NNRT or a PI. And when their counts, CD4 counts are dropping below 200, that's typically when you start prophylaxis. And of course, they should be screened for newly diagnosed patients should be screened for opportunistic diseases, STDs, and annually get TB screening. And lastly, the complications. So what does the AFP key recommendation say? That if they're having HIV-associated neurocognitive disorder symptoms, they should be screened for those. There's, for example, HIV dementia complex. There's a HIV dementia screening tool online which you can use. And if they're on PIs and they're having lipid derangements, so how do you manage them? Well, the AFP says you manage them like anyone else according to the NCEP ATP3 guidelines. There's standard protocols from them. You manage them the same way. They should be screened for kidney disease, and those who are at increased risk should have annual kidney disease screening, which may not be the same for a healthy person otherwise. You may not screen them for 2 or 3 years. And they should get their fasting glucose and lipid profiles at least every 6 to 12 months. And of course, those who are on therapy, check for potential drug interactions, especially if they're on PIs. So I'd like to thank everybody, and Dr. Katsela, Dr. Mack, Dr. Corey, Dr. Pikett, Dr. Manik, and all the other faculty in the family medicine faculty, Dr. Sharma, of course, Trista, the CME department, and especially my wife, who was able to put up with me for the last few days.
The last few days?
Questions?
You did a fabulous job. One more time, please. Any question for anyone?
Thank you.
One other way you can ask question is to email. Just have